hallway medicine, by the way. What do you think of hallway medicine here?
There's no one here.
Someone's in our studio operating.
Yes, the nerve. Hi, welcome to another episode of Talking with Docs. I'm Dr. Brad Weening.
And I'm Dr. Paul Zalzal.
On today's post-Canadian Thanksgiving episode, Paul, we're going to talk about a very interesting topic, a baker cyst, someone that may have been involved preparing Thanksgiving dinner.
Ooh, or maybe the dessert for the baker cyst.
Yes.
Good one.
Okay.
Is that where it comes from? A baker?
Well, I suspect you're going to tell me the etymology of the term.
Well, I looked it up recently,
Okay.
and a baker cyst, which is a cyst behind your knee, which
Yep.
we're going to go into, is named after a 19th century physician surgeon named William Baker.
Oh, so he wasn't a baker.
Not a candlestick maker, not a baker, or what's the third?
A butcher.
Butcher, no. No, he was an actual dude.
Okay.
Yeah, I suspect he was like a top of his class, Billy Baker, and they're like, hey, Billy, you're so good we got to name something after you. We're going to name a rash after you.
Sure.
And Bill's like, no, don't name a rash. Give me the bump behind the knee.
Yeah.
Right?
Sure.
The popliteal cyst. Give me that one. So it became known as Baker cyst.
He was probably in a schoolhouse with like 6 kids across
That's it.
9 grades. But
That's right.
okay, so a baker cyst. So yeah, let's start with the definition. What is a baker cyst?
So a Baker cyst is also known as a popliteal cyst, and it refers to a mass behind someone's knee.
Okay.
In the popliteal fossa is the anatomic location, and it's just a bump or a mass or a cyst there.
Right. So, and it's fluid filled typically, so fluid from the joint
Right.
that has squirted out between 2 muscle heads, the medial head of your gastrocnemius, your calf muscle, and semitendinosus, one of the hamstring muscles.
Right, because in your knee, in everyone's knee, there's a little bit of fluid called synovial fluid that allows the joint to lubricate, right?
Okay.
And there's a small amount in there, but in pathologic circumstances like a meniscal tear or arthritis or something like that, there's more fluid made, and some of it leaks out through what ends up being a one-way valve.
Yes.
So every time you bend your knee and move, it pumps some fluid out, but it doesn't let it back in.
Okay. So how do these people present, Paul? Someone that has a baker cyst, how are they going to know it? What are they going to come complaining about?
Very often they come into my office saying, I got a Baker cyst.
Thank you, internet.
Yeah, they've had it. Thank you, ultrasound.
Yes.
Yeah, they've had it diagnosed, and so they come in knowing it is. But usually, what you'd feel is often painless.
Yes.
Bump behind your knee.
Right. So it feels a little bit full.
Yeah.
I know some patients that say to me that they have trouble either getting their knee all the way straight or all the way bent, which actually may or may not be related to the cyst, may be more related to the pathology causing the cyst.
Right, the underlying pathology.
Every now and then, numbness and tingling.
Yeah, you can get some numbness and tingling down the leg if it's pushing on a nerve or something like that.
Okay, so we got our symptoms.
Yeah, typically.
So what do we find in an exam? Anything different than we've talked about already?
On physical exam, you may find some other pathology in the knee, some swelling and effusion,
Yep.
tenderness, signs of arthritis, and you can often palpate or feel a lump behind the knee.
Okay. So once we've done our physical exam, we always lead into extra tests or imaging. Is there any test that's a really good test for this?
Well, we always start with, always in terms of investigations of the knee, we always start with an x-ray.
Right.
Okay? Any other tests?
So I would say usually we're not big advocates of the ultrasound for the knee.
No.
However, this is a good way to diagnose anything that's related to fluid. Ultrasound is good for fluid-filled pathology. So yes, it can help give us the specific location and potentially the size of a cyst. So often an ultrasound will already be done. By
not big advocates of ultrasound of the knee, what Dr. Weening really means is we spend a lot of time telling people not to get an ultrasound of their knee, because I tell people 99% of the time it's useless.
Right.
But this may be the one instance if there is a Baker cyst and for some reason the diagnosis is under question and you're not sure it's a Baker cyst, and it could be something else like a tumor or something more aggressive or something that you're worried about, then an ultrasound can help you in this case. But I don't think every Baker cyst needs an ultrasound.
No, I totally agree with you. Billy Baker would agree. Don't ultrasound me.
No, Bill. He's rolling over in his grave right now. When they invent ultrasound, he's saying don't use it on every knee.
Yes. Okay, so we know we have a Baker cyst.
Yeah.
What are we going to do for it now?
Well, Billy would have gone and cut that out.
Yes.
I think back 100, 200 years ago, they used to excise the Baker cyst.
Right, so maybe he was the butcher.
It could have been. He could have been. You're right. No, so now we don't. We like to say treat the underlying pathology, because the Baker's cyst doesn't usually happen in a normal knee. There's usually some pathology going on, a meniscal tear, arthritis, something like that, and that leads to the extra swelling, extra fluid that leads to the cyst behind the knee.
And usually I'll say to patients, usually the Baker's cyst is a sign of the problem, it's not the cause of the problem, even though there can be some specific symptoms related to the cyst itself. Okay, so we're very, very rarely, I never have, going to excise a Baker's cyst.
Never.
What potential options do we have?
Well, we have physiotherapy to treat the underlying condition.
Yep.
Okay. Anti-inflammatories, topical or oral, to take down the inflammation that might take down the cyst.
Yep.
Ignore it as much as you can. Probably number one.
That's a good one. Just watchful waiting.
Yeah. Yeah. I mean, they've talked about aspiration. I've never done that. I would never advocate that, but I think I've seen that done before.
Certainly in the textbooks it showed you like lying on your stomach. And there's actually some important structures in the back of your knee, so it theoretically could be a little bit dangerous.
Yeah.
What are your thoughts on injection?
Injecting the knee. I would not inject the Baker's cyst, but steroid injection, if the underlying pathology is an inflammatory one that's leading to that, sure, a corticosteroid injection in the knee.
Just to work on reducing the flow, essentially, into the cyst?
Yes.
Okay.
Yes.
I would say one other thing that happens is not really a treatment, but sometimes it ruptures.
Yes.
Okay, so when it ruptures, what are people going to experience? Because this can be concerning.
Right. So imagine if the cyst behind your knee ruptures, the fluid is going to just track down between the muscles into your calf, and it's going to hurt. You're going to feel quite a bit of pain, and it may mimic some other pathology, such as
deep vein thrombosis or a blood clot. So yeah, people have pain and swelling, and it really onsets quite acutely. So people are panicked often, and they go to the ER and they get an ultrasound. To make sure they don't have a blood clot, and they say you got a ruptured Baker's cyst.
Yeah, there you go. You treated yourself.
That's right. That's right.
Right. So I spend a lot of time in the office talking about Baker's cyst. That's why we wanted to make this video.
It's an important one, for sure.
Because it's not a thing that we need to chase after aggressively in terms of treatment.
Yes.
Okay.
You're not going to open up a Baker's cyst clinic.
No.
Although you probably could do well.
You would do very well.
Because people would come.
Yeah. Well, did well for William Baker.
Yes.
Do you know who he later became the assistant to?
No.
Paget, Dr. Paget.
Oh, okay.
Paget's disease. That's a legit one. We'll make another video about Paget's disease.
A lot of our patients will not know that, but that's impressive. I think it was a pretty small circle back in the day.
Yeah, you're pretty well. All four of them would get together and name new diseases and entities. So that's the deal with Baker's cyst.
Yeah, so really common.
Very common.
Might be sore.
Could be sore.
Probably don't need to do much about it.
Leave it alone. It's not a thing. It's not like a thing, like a diagnosis. Don't think of it like a diagnosis. Think of it like Dr. Weening said, the sign of something else that's going on.
All right.
That's Baker's cyst.
That's a nice summary. I think that's going to help people, because a lot of people wonder, what the heck do I need? I haven't done anything about my Baker's cyst yet. I've been too busy. There's a pandemic.
Yeah.
I got to get in for my Baker's cyst.
Put it on the back burner. Yeah.
So if you like it, please like this video, share it, leave a comment.
And remember, you are in charge of your own health.
We'll see you next time.